It is recording. Yeah, go for it.
Well, welcome to our first session here in the Advanced-CTR Biostatistics and Study Design seminars. We've been trying to set these up for a long time, and glad that those of you who are in the room and online have joined us. I'm Chris Schmidt. I'm the head of the cohort here, and I'm also chair of Biostatistics at Brown. And we're really happy to do this. We've had a lot of people asking us for instruction in how to design studies and how to do statistical analysis. And so we have set up two seminars. One will be running on the last Thursday of the month through the spring, and that's going to cover study design. And the other one will be running the first Tuesday of the month, and that will be covering statistical analysis. Really happy to have two of our top students who are going to be running these seminars. So Jess Kaminsky will be doing today. She's going to introduce you to study design, and she will be joined by Gabby Silva, who will both be doing the remainder of the seminars when they're both available. And Gabby is a PhD student in biostatistics at Brown. So we are hoping that this will go well and that you'll spread the news if you like it. This is being recorded, so those of you who online want to, if you missed something, you want to see something more, you can go find the recording, and we're also available for those who are not able to make this. We hope this will be sort of a mini workshop course, so that if you can't make every week, you'll be able to go to the recorded videos and pick up what you've missed, so that we won't lose you along the way. So I'm going to turn it over to Jess, and she'll run this and give you the particulars in terms of what you need to do. So welcome.
Hi, thank you for being here. As Chris said, my name is Jess Kaminsky. I am a second year master's student in the Biostatistics department. And today I will be giving you a brief sort of cursory overview of study design, and the following courses will go into depth about analysis and data collection methods for all of these studies. So the objective for today, what I hope for you to get out of this, is to understand the difference broadly between experimental and observational study designs and the characteristics of each of those. And then within observational and experimental, the different types of study designs that there are and what you might use those for. So why do we need different types of study designs? Simply, different questions require different study designs. So I've listed some example questions. How many people are diagnosed with cancer in Rhode Island every year? Does a new blood pressure medication control high blood pressure better than existing drugs? What role does alcohol play in high blood pressure? And what were the health effects of long-term exposure to the Twin Towers site after 9/11? So as you can see, these are all different questions that would require different forms of analysis, different variables, and different information to answer those questions. So how do these questions and how do these study designs differ? First is the number of observations made. So for a given study, maybe you need multiple observations for one person, or for a different study, you just need to know one observation for your subjects. Second is data collection methods. So are you receiving the information from someone's health records? Is an investigator observing and recording this data? Are you giving subjects a survey and asking them to fill it out? Timing of your data collection, that sort of goes back to how many observations you need on an individual. Also, maybe for your particular research question, it matters specifically what time of day or what time of year the observation is made. Your unit of observation, so are you comparing individuals? Are you comparing groups? Are you comparing individuals within groups? Things like that. The availability of your subjects. So if you're studying a rare disease, rare outcome, it might be hard to get a lot of subjects that have that outcome of interest. And then finally, the assignment of your exposure. So the treatment that you're testing out or the exposure that you are interested in, how are the subjects, how are the people that you're studying receiving that treatment or exposure? Are you assigning it to them, or is it something that's just happening naturally? So before we move on into explaining the different types of studies, I want to go over what a variable is, because the type of variable that you're using will affect the type of study that you are going to conduct. So simply put, a variable is something that varies and can take on different values. Your exposure variable, other names for it are independent variable. In statistical analysis, it would be your predictor or your X value, your determinant, or your risk factor. So say you were conducting a clinical trial, you developed a new drug that you think relieves headache symptoms much faster than anything that's on the market. So your exposure variable is this new drug. Then your outcome variable, it's your dependent variable. Again, in analysis, it's your response, it's your Y value. It's also the disease or the health effective interest. So in this case, the health effective interest would be time to headache relief. So these are the two main variables that we're going to be considering throughout all these different study designs, and depending on what you have, we'll sort of mandate what study design you're going to use. But in general, overall, the goal of your research is to determine what the relationship between your exposure and outcome is. So here's just like a broad map of the different types, and you can see what types of studies fall under what general type of study design. So you have experimental or observational. Within experimental, we have RCT or randomized controlled trial, and quasi-experimental. And then observational, we have the ones listed. There are a handful of other observational studies that you might consider, but these are the ones that we're going to go into today. So very broadly, what's the difference between an experimental study and an observational study? In an experimental, this is a much more formal study. You have an investigator, you have a research question, you have an investigator who is selecting participants to be in the study, and then through some randomization scheme, assigning the treatment or the exposure to subjects in the study. It's often referred to as a gold standard of research because the way that you set up the design, it allows you to draw conclusions and compare groups much easier than certain observational. In an observational study, you are sort of just taking advantage of things that are happening naturally. You're not manipulating what's happening to people, and you're not imposing any sort of treatment or exposure on them. With that, there's no randomization. Also, just by nature, it's more common because you don't have to set up a trial. You can just, again, observe what's happening. Just this table, I think, lays it out nicely. So observational, we're not manipulating what's happening to people. We're taking advantage of what's happening to them. And therefore, we're not randomizing or assigning a treatment or exposure to them. But in experimental design, we are doing both those things. Quasi-experimental, you have a little bit of both. You're not controlling or randomizing the exposure, but there is some manipulation in the exposure that people receive, and we'll give an example of that later. So starting with experimental design, the gold standard RCT. This map, I think, provides a nice way for you to see sort of the flow of an RCT. So you have some sort of study population, which is defined based on your research question. Then, as I said, the key feature of an RCT is that there's some sort of scheme where you're randomly assigning people to a current treatment or a new treatment, or maybe, if we go back to that headache medicine example, a full dose versus a half dose versus what's already on the market, or in some cases you might have also a placebo. Once you assign, you hope that the subjects will follow your treatment protocol, and then everyone's going to be classified into whether they improve or do not improve, or whatever sort of outcome that you are interested in. So randomization, as I was saying, is an important feature of the RCT, but there needs to be a bit of a distinction. So random selection is the choice of your population. So if we go back, this study population at the top, random selection is what's used to classify people into that. So maybe you have a group of people who are eligible for the study through some sort of inclusion and exclusion criteria. However, because of funding, you can't enroll everyone into your study. So you have some way of randomly choosing who actually will be in the study. But then once you have that study population, the people that are going to participate, you then randomize those individuals into your different treatment groups through like different randomizations. Why do we randomize? What makes randomization important, and why does that make the RCT a great way to do research? So we are allocating subjects into 2 or more treatment groups. This helps ensure that all your groups are balanced. It's not guaranteed that we're going to see balance, but a successful randomization would achieve balance. And what I mean by balance is, so say in the study that we're doing, we have one treatment group and 1 control group. We hope to see the same distribution of men and women approximately in both groups. We hope that the average age of the individuals in both groups will be approximately the same. And this allows us to compare the groups and control for things that we're not measuring. And so then the results that we do see, we can confidently say that it's because of the exposure that we're imposing. Okay, so I'm going to briefly go into this, but we will go into this more on the specific experimental seminar. But so some methods that help with bias in our RCTs, allocation concealment. So this goes to the randomizations of the subjects in your trial. So what this means is, say you have someone who is assigning patients. They're coming through the door, and as they do, you're assigning them a treatment group. Allocation concealment means that the person who is giving these assignments does not know the order in which the assignment is being given. So say the way that you are assigning is you have envelopes, and in each envelope it just says treatment group or control group. Allocation concealment means that the person handing out those envelopes does not know the order of what's in the envelopes. This is to help with selection bias, so we're not, for some reason, choosing certain types of people, consciously or subconsciously, to be in a treatment or control group. The other method is blinding. So there are multiple tiers of blinding. So first is single blinded. That means that the patient receiving the treatment does not know what treatment they're receiving. So are you taking a placebo pill or are you actually taking the drug? They don't know. Double blinded means that the patient and the investigator both do not know the treatment that the patient is receiving. And then finally, triple blinded means that the patient, the investigator, and the data analyst do not know which group the patients are in. And then in analysis, so anytime that you are assigning subjects to take a drug or to do something sort of outside of your watch, it's completely possible that they're not going to comply and follow the procedure that you have recommended for them. So with that in mind, there are different analysis techniques that you could consider employing based on how many non-compliers you have. And this we'll get into more in another seminar, but the 2 different types are intent to treat analysis and efficacy analysis. Other kinds of RCTs, these are just like RCTs, but they have small caveats. So the group randomized trial is you are assigning treatment to a group. You're still comparing individuals, but their treatment that they receive is based on a group. So you want to try some sort of some sort of study where you're comparing, again, two different drugs. But instead of just assigning to individuals, what you might do is hospital A, all the patients at hospital A are going to try drug A. All the patients at hospital B are going to try drug B, and maybe all the patients at hospital C are going to try a placebo. So the way that you're randomizing is just a little different. It's by groups that people are sort of naturally in. But then once you have your data and you have your results, you're going to compare among the individuals. The second type is a crossover trial. So this is a type of RCT where you're kind of comparing individuals to themselves. So what's going to happen is they are going to take one treatment to start with. They're going to record their results. And then there's going to be sort of a washout period where they're not taking the treatment. And then they're going to take the other treatment, and you're going to get their results. So this is an individual analysis, and you're comparing individuals to themselves to see the results. Okay, and then the last type of experimental study that we're going to talk about, quasi-experimental. So quasi-experimental is similar to the RCT as I showed you, but we're not randomizing, and the exposure is not controlled by a study or an investigator. So as an example, we had there's two cities about the same size, and their water was fluoride deficient. One of the cities decided to add fluoride to their water. The other one did not. So no investigator made that decision, but we do have two different groups of people who are receiving two different sort of treatments. And then what they found was there was a significant reduction in cavities in the community with fluoride. So this first question, what is the key assumption about the assignment of exposure in these types of studies? Any ideas? So the key assumption is that we are not randomizing the exposure, right? It's observational in that this is what's naturally happening. This was what those communities decided, but we're going to take advantage of that and use these two different groups and compare them. One other example of quasi-experimental design, in Utah, they were looking at air pollution and preterm birth. So we're comparing in the Utah Valley where there's a steel mill, and then outside of the Utah Valley. The steel mill closed for approximately 1 year, and what you see is this dip in the percentage of preterm births. But there was no change in preterm birth in the other areas of Utah. So again, the investigators did not assign the steel mill to be closed or assign people to live in these groups, but this is what was naturally happening, and we were able to then compare and draw some conclusions about the steel mill pollution and preterm births. Okay, so some strengths and limitations of experimental design. First, you're able to demonstrate causal association. The investigators are in control of the intervention, so they're directly in control of the dosage and the treatment that you're receiving. As I said, randomization is very important. It deals with known and unknown confounders that may be sort of clouding your results and interpretations. And as I spoke about, blinding and allocation concealment prevent certain types of bias in your analysis. Limitations, there are ethical concerns, which is why also a strength of observational designs. You can't impose some, for example, if you want to study smoking and pregnancy, you can't force someone who's pregnant to smoke, but if they are already smoking, you can do that. So you could never ask that question in an experimental design. Artificial trial conditions are not like general practice. So you're setting up a trial, you have individuals from a certain population, and you might not be able to generalize it to everyone. And as I also touched on before, it can be expensive and very time consuming to sort of set up this study, enroll participants, keep them through, and follow up with them. Okay, next, observational study design. So as I said, these are the types of observational studies that we're going to go over. But in general, what is an observational study? We observe nature without intervention. We're taking advantage of what people are doing. Choices, behaviors, occupation, environment, where they live. We want to mimic an experimental study as much as we can. They're common out of necessity, one, because we can maybe work with treatments that might not have been ethical in an experimental sense. Strengths and limitations in general. You can understand, you can measure multiple exposures and outcomes just based on what people are doing, observing and documenting that. You have a chance to understand the natural course of disease if you are just following individuals, following what they're doing, not imposing anything on them. If a disease develops, we can sort of analyze what they did and make conjectures about what might have caused that. And again, we can study exposures that would be unethical to expose people to. Limitations, exposure is usually not randomly assigned. So we're not necessarily achieving the same sort of balance that we were achieving in an experimental design among the groups. It may be difficult to measure your exposure. So sometimes in certain types of observational studies, we are collecting people who already have a disease, and then we're asking them questions about things that they did or things that they were exposed to. So that sets us up to have some recall bias. So if you have a disease, you might be more inclined to remember something, not remember something, think you were exposed to something or not based on your disease status. So as self-reports can have poor validity and reliability. So descriptive studies. So this is in that map I showed you, this should actually maybe be another branch because a couple of the studies that we're going to talk about fall under observational descriptive studies. So descriptive studies describe the pattern of disease occurrence. We want to understand who is affected by disease and when and where and to what magnitude. So this has two benefits. First, if we can understand the burden of disease, for administrative program planning, we can allocate resources more effectively. If we know certain areas have a higher burden of disease, we can focus on that. Second is for scientific hypothesis generation. So most of these, we're not going to be doing any sort of statistical analysis or drawing any statistical conclusions. However, we can use these descriptions and sort of narratives that physicians will write to ask new questions and then maybe use that to start an RCT or things like that. So disease clusters and epidemics are two types of descriptive studies. So if you have an anomaly of increase in cancer over time in a small town, you might not run a statistical analysis on this. You don't have anything to compare it to. However, it would certainly be something that you would want to document and put out so then people could read about it and then maybe form their own hypotheses. And same with epidemics. So descriptive studies, case reports and case series. These are tend to be in the form of a narrative, and they can be about one individual. Describe the medical history of a single patient in the form of a story. So a clinician will see something unusual, whether that's signs and symptoms, or a patient is receiving a new novel treatment, or a patient has some sort of event or symptoms that suggest an unexpected causal relationship. Someone will write about this and publish it. There's no statistical analysis or comparison because it's just about one individual. With case reports, you can also have case series, which is many case reports, usually with a similar outcome, that are grouped together. And again, people can sort of read through these and then ask questions and try to generate hypotheses. Okay. So the strengths and limitations of these, they're very simple. They're very rapid. This could just be someone writing it. And as I said, generating hypotheses. Limitations, we can't really make conclusions about treatment efficacy or the natural progression of the disease. We're not really comparing it to anything. It's more just a story. And then it may contain incomplete data, especially in a case series if you have, you're grouping things by the same outcome. But you might have different information on different subjects. And there's no hypothesis testing, no analysis. Okay. The next type of observational design is a cross-sectional study. So in general, a cross-sectional study is your subjects in your study are not based on their disease status, what outcome they have, and they're not based on their exposure. So maybe you're looking at lung cancer and secondhand smoke exposure. If you were doing a cross-sectional study, you would not choose people based on their exposure to the smoke, and you would not choose them based on their lung cancer status. A cross-sectional study is just one single snapshot in time. So you get your study population, and then you determine whether or not they were exposed and whether or not they have the disease, and that's it. This can help us identify prevalent cases over a long period of time. However, because we're only taking one little snapshot, we don't know what happened before, and we don't know what's going to happen after, so we can't really say, even if the disease came before the exposure or vice versa. Here is a map of cross-sectional. So as I said, you define your population. In one moment of time, you gather data on all of your subjects, and you can then classify them into one of these 4 boxes. So with that, we come to the 2x2 table, which can be used in many of these different study designs, but I'm going to use cross-sectional to explain it. So based on the 4 colored boxes at the bottom, we basically have a number of people that fall into each of those categories. You can then fill in those people into these tables, A, B, C, and D. These are just the counts. So A is the number of people exposed with the disease. C is the number of people with the disease who are unexposed, things like that. There are a lot of things that we can do with these tables and these numbers, but I'm going to just start with I'm just going to start with these. So if you want to take a minute and try and figure out how you would calculate these numbers and these proportions, and then we can go over it. Some of these are going to be adding up some of the boxes, some of these are going to be individual boxes, and then some of these are going to be a combination of proportions and additions. Okay, so we'll start with the simplest one, I think, which is the total number in the study. So using this table, how would you figure out how many people were in this study?
Summing everything up.
Yeah, perfect. I went over the total number exposed. No, I did not. Total number exposed, which one's that? A and B, perfect. Total number unexposed, C and D. Total number diseased, then we're just going the other way, A and C, no disease, B and D. Some of these are cut off, but I think they're just the number exposed with disease, exposed with no disease, and those are A, B, C, D, but we'll see that on the next slide where it's all written. Proportions. So proportion of exposed with the disease. So out of those people who were exposed, out of those people who were exposed to secondhand smoke, how many of them have lung cancer? So that's going to be A. Yeah, perfect. A over A plus B. Exposed and disease divided by the number exposed. I'll go ahead and advance. These are all the numbers. The only ones that were cut off were the four A, B, C, D. So in the seminar that talks about cross-sectional studies, we'll go into more depth of this table and also how to use it in then statistical analyses and different questions that you can ask of these numbers in this table. Strengths and limitations of cross-sectional studies. It's less time and resource, again, just by nature and being an observational study, but also because you have no follow-up time. You find your subjects and then you get your measurements on them, and that's it. Then you'll do your data analysis, but you don't need to follow up. You don't need to follow a protocol or set up an intent study. Limitations, you can't, again, we talked about this, you don't know the order that things happen, so you can't make claims about what caused what. This is not good for rare exposures or outcomes. Why? Because there's a chance if you're interested in some sort of rare exposure, some sort of rare outcome, there's a chance that the population of people that you pick, no one has the outcome and no one has the exposure. And then you would have no information on things that you just. Next is cohort studies. So what is a cohort? A cohort is a group of people with common characteristics, and in a cohort study, we're following them over time. In this type of study, we are actually starting with people who have our exposure of interest or don't. Then we follow them over time to see who develops the disease or what sort of symptoms they do develop. So here your analysis is the risk of the outcome, the risk of lung cancer in those who were exposed to secondhand smoke versus not exposed to secondhand smoke. This is a map of this one. So there's no assignment to the exposure. We are specifically seeking out those who have the exposure and those who do not. Excuse me, and then following them over time. Cohort studies come in sort of two different types. We have prospective and retrospective. So prospective is we're sort of what I just described. You find subjects who have the exposure and do not, and then just sort of wait and see what happens and follow them over time. Retrospective, it's what happened in the past. So we find people who have our outcomes of interest and our disease of interest. And then we go back in time, if we can, to figure out when they were exposed. So it's the same thing, but the data is just already available for you instead of having to wait. So just some more details about perspective. These people do not yet have the outcome. Retrospective, they do. These people are at risk of developing the outcome, which is why we've included them. And we follow them into the future to see what happens. But the downside of this type of study is it can take a very long time to complete. map of this study. So this is just showing prospective. We're looking over time. And in this example, this could take 20 years, which is downside. People might not want to start a study that's going to take them this long. You might not be able to get funding for a study that's going to take this long. So if you can, a retrospective study might be a good alternative because you already have all the data. You just need to analyze it. So some strengths and limitations of cohort studies. You can differentiate cause and effect here, unlike in cross-sectional where you don't know the order of things that happened. Here, you know people were exposed and then got a disease or did not. Which also reduces the recall bias because we're not asking people to remember whether or not they were exposed to something. This is efficient for rare exposures because if you want people with some rare exposure, you at the beginning of the study are choosing who has groups of people who have the exposure and do not. So you can find and include as many people with that exposure as you want or need. Again, limitations, the long-term follow-up can take a very long time, it's expensive, and it's difficult to study rare outcomes because again, even if the people have the exposure that you're interested in, if the outcome is incredibly rare, there's a chance that few or none of the participants actually develop that. Okay, case control studies. So in a case control, you have cases and controls. So cases are the individuals who have the disease that you're interested in, and the controls do not. So it might feel like a backwards cohort study where we're doing the opposite. We have those with the disease and who don't. And then we're looking back to see who was and was not exposed. So it's just different what we're starting with. Here is a diagram. So it's kind of flipped because we're starting at the bottom. We're getting these people and putting them into the have disease or do not, and then we're looking backwards. So the exposure and the outcome have occurred before we started the study. We're assessing their outcome before we know their exposure, which is different than some of the other studies that we've talked about. The analysis focuses on the odds of being exposed, given that you have the disease, compared to the odds of being exposed, given that you do not have. So case control, this one is efficient for rare outcomes because we are choosing our subjects based on what their outcome is. So we can just go ahead and find all the individuals that we need or want with that outcome and put them in our study population. Here we may not be able to discern temporal associations. Subject to recall bias, where if we don't have specific records on these individuals of what happened before their disease, we have to ask them, and that may lead to inaccurate results. And we need to be able to clearly define who our cases are. So it needs to be an outcome that can be explicitly designed, maybe by a test or some sort of status. It can't be, for example, in the headache example, it can't be the time to pain relief, because that's sort of a little less well-defined than actually happening. Okay. The next type of observational design, it can also be considered one of the descriptive observational designs, is an ecological study. So here we are studying groups, and we are comparing groups. The unit of analysis is groups rather than individuals. Information about the exposure and the outcome is measured at the group level, usually by averages within that group. So as an example, this is about the relationship between fertility and infant mortality in sub-Saharan Africa. And so here our unit of analysis is groups, countries rather. So on the x-axis, we have infant mortality rate for 2000 to 2004. And so that is that rate for that country. And then on the y-axis, we have the average number of children per woman. So that's the average for that country. With this, we're subject to the ecological fallacy. So we don't have the outcome and exposure data for individuals. Right? We have the information about the country, but the country is made up of a bunch of individuals. And so this type of design, we're failing to account for the variation between individuals and group. Certainly these characteristics, the mortality rate and the number of children is going to be different for every person. But within this type of study, we're grouping them all together and kind of saying that they're the same, and we're assuming that these group characteristics apply to everyone. So we're losing some sort of information when we decide to do a study in this way. The study can be quick and inexpensive. Based on your research question, it might be the most appropriate thing to do. It's useful when there's little data on individuals, and you can just, it allows you to use averages. Some limitations to this, the ecological fallacy, as I just said, secondary data sources, you might be getting these means or these rates from a survey or something like that rather than collecting them yourself. And then particularly migration across groups. So in the example we just showed, maybe women are moving among different countries. And so we're sort of grouping them by country, but it is very possible that these people can change groups. And we have not accounted for that. Okay. So now we are going to do an exercise based on all of these studies. So I will give you some time to try and fill out this table. The first two columns, you're going to fill in individual or group. And then the last two columns, it's going to be yes or no.
All right. So I will go ahead and advance the slide. And at least if the individuals in the room want to discuss or have questions, we can. So in RCT, we are observing individuals and we're analyzing individuals. The exposure is assessed before the outcome, right? Because we're assigning people to groups based on their exposure, and then we wait to determine the outcome. A characteristic of the experimental RCT and group RCT is that the investigator controls the exposure. And then we see that the only difference with that group RCT is that we are observing based on groups and assigning treatment based on groups, but then within the analysis, it's still within the individual. A cohort study, following the groups over time, we're observing and analyzing individuals. Is the exposure assessed before the outcome? Yes, we are. That's sort of in the definition of that type of study. We choose people based on their exposure status and then follow them. But it being an observational design, we are not controlling the exposure. Case control, individuals. The exposure is not assessed before the outcome. In this case, they're actually assessed at the same time because that's the one that's just that snapshot, and then we determine. Again, being observational, no control of the exposure. I think I just described cross-sectional, but they have the same results. Cross-sectional is the snapshot. Case control, same thing, but we're getting cases and controls. Here, it's not that they're assessed at the same time, it's that actually the outcome is assessed before the exposure. And then ecological, both observing and analyzing based on groups. We are not assessing the exposure before the outcome, and being, again, observational, we are not controlling the exposure. Are there any questions on that? Okay. Okay, so next we are going to give some examples of different studies and then talk about which design they should be. So starting here, choose the appropriate design if you want to identify causes of rare disease. So we're looking for the study that is best for studying rare outcomes.
Case control.
Yeah, perfect. Next, identify long-term effects of rare exposure. So the type of study design that's efficient for rare exposures rather than outcomes. So this one is going to be cohort, particularly. I think it could be either, but this one is listed as retrospective. I think that comes with the long-term effects. Identify causes of new disease about which little is known. So this one I think is a little tricky, but I think it falls in the same category as being a rare disease. It's a new disease. You don't have a lot of information about it. You might not even have a lot of known or documented cases about it. So therefore, it is also a case control. So the next ones are actual examples of studies, and then we're going to try to identify what the study design was in that particular case. So study examines death rates from cervical cancer in each of the 50 US states in relation to average percentage of women in each state undergoing annual pap smear screening. So this one, the key is the 50 US states, and we're comparing the average percentage of women in each state. So we have groups. So this one's going to be ecological study. In a study begun in 1965, a group of 3,000 adults in Baltimore were asked about alcohol consumption. The occurrence of cases of cancer between 1981 and 1995 was studied in this group. So here for this one, the dates are important and the fact that we are looking at groups is important. Yeah, perfect. Prospective cohort study. Okay. Study compares current prevalence of back pain among current members of the Plumbers and Pipefitters Union with that of current members of the Bakers and Confectionery Union. The key thing to see here is the repeating of the word current. Cross-sectional. That's okay. Cross-sectional because it's just current. So one snapshot in time of all of these different prevalences of back pain among these groups. Okay. Study evaluates relationship between breast cancer and a woman's history of breastfeeding. The investigator selects women with breast cancer and women who live in the same neighborhoods as the women with breast cancer. Study subjects are interviewed to determine if they breastfed any of their children. So in this one, we have women with breast cancer and women who do not have breast cancer, and we're comparing them based on a type of exposure, which in this case is breastfeeding. So for this one, it's going to be case control. We have cases and we have controls, and we're comparing them. Study evaluates two treatments for breast cancer. Women with stage 1 breast cancer are randomized to receive either lumpectomy alone or lumpectomy with breast radiation. Women are followed for 5 years to determine if there are any differences in breast cancer recurrence and survival. RCT, yeah. Experimental RCT, perfect. Study of relationship between exposure to chest irradiation and subsequent risk of breast cancer began in 2005. In this study, women who received radiation therapy for postpartum metitis, inflammation of breast cancer that occurs after giving birth, in the 1940s were compared to women who received non-radiation therapy. Women were followed for 50 to 60 years to determine incidence rates of breast cancer. Retrospective cohort. Yep. We have groups and then we have dates, but we're going back in time. We started this in 2005, but we're looking at data from the 1940s. Okay. So some brief review about, I just want to highlight the differences between these two. So overall, observational versus experimental. Observational, we're looking at prevention or treatment or the natural progression of disease. We're looking at some sort of moderate or large effect. A trial is not feasible generally or ethical, and trial can be too expensive because these typically have larger sample sizes. Experimental, question involves prevention or treatment. Small effect expected because it is a trial, because you're usually dependent on funding and timing. You'll have less subjects, but we're doing ethical, feasible research questions. But with this, there are resources available because you can get funding for these trials. Cohort versus case control. So a cohort study is for a rare exposure. A case control study is for a rare outcome. Cohorts is when you don't know a lot about your exposure. Case control is when you don't know a lot about your outcome. Cohort, you want to evaluate several effects of your exposure. You can look at multiple different outcomes. Case control, you want to evaluate several different exposures. So we can see sort of the parallel between these two here, and it's just dependent on what kind of question that you want to ask. I think those are the key things about the differences between these two. Retrospective versus prospective. So retrospective is looking back, prospective is going forward. It just depends on sort of the time and the resources that you have and maybe the question that you're asking. So some take-home points. Different study designs are necessary for different ways of harvesting information, for different ways of answering questions that you might have. The choice of study design that you use is very dependent on what your question is, the disease that you're studying, the characteristics. Is it rare? The outcome, is that rare? The state of current knowledge, how much is known already about this disease or exposure? Frequency, again, of the exposure and the outcome. What do you expect to see? What's the expected relationship between this outcome and exposure, and what association do you expect to see? Validity and efficiency considerations. So as an example, looking back in a study where there might be recall bias, that might be a validity concern. And if that's important to you, you might not choose that type of study design. And finally, practical and ethical considerations. Does anyone have any questions? Okay, so our next topics, Gabby on Tuesday will be presenting about exploratory data analysis. And then the fourth Thursday of March, we will go into experimental study design, but we'll dive much deeper into the topic, and we'll talk more about in depth about analysis techniques and things like that.
What would you call a study where you're looking at, prospective, you recruit a bunch of patients, prospective follow up, using various outcome measures? It says it's looking at changes over time.
Mm-hmm.
You don't have control.
So your question is, you have two groups. You don't have a control. Oh, one group, and you're following them over time. You don't have control. And you're looking to see what outcome measures change with the disease. Well, I think it falls under descriptive if you don't have a control group. But I don't really know what it would fall under if because you're not comparing it to anything. What are your comparisons?
Baseline versus follow-up.
Mm-hmm.
Baseline would be the start of your observation time. Like you have time point 0, that's the baseline, and then 1 year after that, you measure again. And this would be a comparison, so you have a time.
Mm-hmm. So I think it's descriptive. It's also longitudinal.
Well, what's the purpose of the study?
To understand the disease progression.
So everybody has the disease?
Yes.
So they're all cases. So. Yeah, I mean, it's just basically it's a descriptive cohort, but it's not a cohort study. It's narrative.
Mm-hmm.
Yeah, it's a cohort of people with disease.
Right, so that's why I was,
Yeah.
but you wouldn't call it.
I mean, you can think of a cohort as a group of people you would follow over time.
So in that sense, it's a cohort study, but it's not like a comparative cohort study. So what we'd be talking about.
We might try to look at the people with the disease and then see over time which of them died or which are better or worse outcome. In more of a cohort study.
Yeah, and you might look at it.
That might influence whether they have longer sort of survival.
Right, and then you would want to go back and find out if you have any.
Well, that was why I was asking the question initially, what you were looking for, because if it was people with the disease, and then you're going to follow them to see what happens to them, and what might have been associated with what happened to them, then it would be a cohort study. It would really be prospective. But your population would be people with disease, everybody in the population.
But you also might have you might have groups within your disease group, right? Like severe progression versus a non-severe progression, right? So if you can group afterwards, kind of your outcome, and you group and you see the difference. So that's the comparison. But I don't know what this would follow.
Mm-hmm.
I think it's defining the question you want to answer. Is it whether certain people better than others, or some good infectious disease or something? And you might have to then divide it to the group that has the outcome that the setback doesn't. But all of them are people who have the disease.
We agreed on cohort, right?
Yes, and then there's all those groups like.
Yeah, I mean, the key idea with a lot of these studies is that they're all gonna have different biases, right? So that's what we've been talking about, the advantages and disadvantages, right? So again, it goes to the question you're asking, and what biases are you trying to prevent, and what could you prevent with which design? You know, so in this case, you want to make sure that the people are somehow representative of some group, and this group would hope that a lot of times it's a convenience cohort, people you have available, but you're hoping that they're representative of everybody you have. But it might just be people in Rhode Island, for example, or people at a particular hospital, in a particular practice. So, are there any questions online? Or do we...
You might just repeat that in case people didn't.
Yeah, say if there's any questions.
Oh, is it, if there's any questions online, we can answer them now. But also for the people in the room, thank you for attending. Allison has a survey. If you could fill it out, it would be great. I would appreciate feedback. We're doing a bunch of these, and if you have any recommendations on how I could improve, that'd be great. Thank you. Just stop share. I'll let you do it. Okay. Stop recording.